Hello everyone, my name is Wei. Today I'll talk about cystitis, pyelonephritis, and renal calculi. I will compare their clinical presentation, diagnostic evaluation, and management. Urinary tract pain or discomfort is a common chief complaint among all three conditions. Patients may present with dysuria, urinary frequency, urgency, flank pain, or hematuria. Cystitis is a lower UTI that causes inflammation of the bladder and most commonly occurs when bacteria ascend through the urethra into the bladder. Pyelonephritis is an upper UTI that develops when bacteria spread from the bladder to the kidneys, causing inflammation of the renal pelvis and kidney tissue. Renal calculi or kidney stones develop when minerals and salts in the urine crystallize and form stones within the urinary tract. These stones may irritate the urinary tract or obstruct urine flow. Review of symptoms. Patients with cystitis typically report dysuria, urinary frequency, urgency, and suprapubic discomfort without systemic symptoms. Patients with pyelonephritis often report fever, chills, flank pain, and nausea or vomiting. Patients with kidney stones usually report sudden severe colicky pain that radiates to the groin and may have hematuria. We will look at some key physical exam findings. Patients with cystitis are generally well appearing and they may have mild suprapubic tenderness without CVA tenderness. Patients with pyelonephritis often have fever, tachycardia, and CVA tenderness. Patients with kidney stone may also have flank or CVA tenderness, but they are often restless because of severe pain and may appear uncomfortable. So fever tends to support a diagnosis of pyelonephritis. Severe colicky pain and patient restlessness are more of a characteristic of kidney stone. Urinalysis or UA is an important initial diagnostic test for all three conditions. For cystitis, UA commonly shows pyuria, bacteriuria, positive leukocyte esterase, and positive nitrites. In some women with classic symptoms such as dysuria and urinary frequency without vaginal symptoms, the diagnosis may even be made based on symptoms alone. Urine culture is the definitive test for identifying the causative organism and is typically reserved for recurrent, complicated, or atypical cases. For pyelonephritis, we obtain both UA and urine culture. Pyuria, bacteriuria, and positive nitrates may also be present. However, the presence of white blood cell casts support upper urinary tract involvement and helps differentiate pyelonephritis from cystitis. Urine culture helps confirm the infection and guides antibiotic selection. For kidney stones, UA often shows hematuria. Many uncomplicated cases are initially evaluated with the history, physical exam, and urinalysis. Non-contrast CT of the abdomen and pelvis remains the gold standard and confirmatory test because it identifies stone size, location, and obstruction. Ultrasound may be preferred in pregnancy or when radiation exposure is a concern. Medical management for cystitis. Most cases of uncomplicated lower UTI can be managed in primary care. Some first-line treatments include nitrofurantoin or macrobid, Bactrim double-strength or fosfomycin. Second-line options include amoxicillin clavulanate or fluoroquinolone such as Cipro when they are clinically appropriate. Most patients do not require referral. Referral may be needed for recurrent infections, persistent hematuria, structural abnormalities, or treatment failure. They should return if symptoms do not improve within 48 to 72 hours or if the symptoms become worse. Patient education includes completing the antibiotic course, maintaining hydration, and practicing preventive measures such as wiping from front to back and voiding after intercourse. Patients should seek care if symptoms worsen or systemic symptoms develop. For pyelonephritis, first-line outpatient treatment includes fluoroquinolones such as ciprofloxacin or levofloxacin. Trimethoprim sulmetazole, which is Bactrim double strength, may also be used based on culture results. Ceftriaxone IM or IV may be given before oral antibiotic when resistance is a concern. Patients with severe illness, sepsis, urinary obstruction, pregnancy, or inability to tolerate oral medications may require hospitalization and IV antibiotics. Referral is indicated for urinary obstruction, renal abscess, infected stones, recurrent pyelonephritis, or suspected urinary tract abnormalities. Patients should follow up within 48 to 72 hours if symptoms do not improve or sooner if symptoms worsen. Patients should complete the antibiotic course, maintain adequate hydration, and seek immediate medical attention for worsening fever, persistent vomiting, worsening flank pain, or other signs of systemic illness. Medical management for kidney stones. Many uncomplicated cases can be managed conservatively in primary care. First-line treatment includes NSAIDs for pain control. They can do ibuprofen 600 mg every 6 to 8 hours as needed. And for certain stones measuring 5 to 10 milliliter in size, medical explosive therapy with an alpha blocker such as Flomax, tamsulosin may facilitate stone passage. Patients who do not pass the stone, they may require procedural stone removal. Patients should follow up within 1 to 2 weeks to monitor symptom improvement and stone passage. Referral is indicated for stones larger than 10 milliliter, urinary obstruction, infection, acute kidney injury, uncontrolled pain, or failure of conservative management. Patients should increase fluid intake to produce at least 2.5 liters of urine per day, reduce sodium intake, maintain normal dietary calcium intake, and strain urine when instructed. They should seek immediate medical attention for fever, inability to urinate, persistent vomiting, or uncontrolled pain. To summarize, cystitis, pyelonephritis, and renal calculi can present with many of the same urinary symptoms. Patients with cystitis typically present with lower urinary tract symptoms without systemic illness. In contrast, fever and CVA tenderness are more concerning for pyelonephritis. Kidney stones are more likely to present with sudden severe colicky flank pain that radiates to the groin and may be accompanied by hematuria. Diagnostic findings can also help distinguish among these conditions. White blood cell casts support pyelonephritis. Hematuria and stone visualization on CT are more suggestive of kidney stones. Recognizing these key differences can help guide appropriate diagnosis, treatment, follow-up, and referral. The following slides contain the references used throughout this presentation. My name is Wei, and I will be happy to answer any questions. Thank you for your time and attention. Have a good day.